So very good evening and a warm welcome to everyone. And at the outset, before I begin, I'd like to take this opportunity to congratulate the organizers for putting together this wonderful conference and also thank them for the opportunity. So I think we're all set for the big debate today, which is on TNT, total neoadjuvant therapy versus conventional chemoradiation. But my question was, when I looked at the debate, should there even be any debate at all? I think TNT has already become standard of care. And I'm really glad that I'm not on the other end. I'm talking for TNT. So I think there absolutely is no debate on this. And when you look at history also, and what it has taught us over the period of years, is that we've started with adjuvant radiotherapy, and then we realized that neoadjuvant radiotherapy was much better, and so on and so forth. Even if you look at the data for adjuvant chemotherapy, that's very weak. And what we have seen is the neoadjuvant strategy has actually led to better outcomes over the period of time. And currently, we are in the era of total neoadjuvant therapy, and that's become the standard of care. And the future will be watch and wait, which I'll be touching on later as well. So if you don't learn from history, I think we'll end up making the same mistakes over and again. So if you look at how the NCCN puts it, or even if you look at this concept called the good, the bad, and the ugly of rectal cancers, we know anything up to T2 is probably good subset, where even stage surgery is absolutely feasible. Anything with T3 or N positive becomes bad, and T4, and or if the CRM is threatened, or if you have the MRF misrectal aphasia being involved, then it's an ugly subset of tumors where they become locally unresectable. So I think there is no debate on the good subset. The point that we're trying to debate today is only on the bad and the ugly subset of tumors. So I just wanted to make that very clear. And obviously, there's just no one size that does fit all. So you'll have to really find a tailoring treatment according to the patient's presentation, be it a good, bad, or an ugly subset of tumor. And again, I think this is the subset that's most likely to benefit from total neoadjuvant therapy. That is the patients with a poor prognosis who fall into the bad and the ugly subset of tumors, who have a CRM of less than 1 millimeter, or low rectal tumors where the intersphincteric plane is involved, and anything T4 or EMV, extramural vascular invasion present on an MRI, and N2 or lateral lymph nodes. I think this is where TNT has really made an impact in this subset of patients. So let's look at a bit of history again. This is what the standard of care was probably a couple of years back, before ASCO 2020. We could do long course chemoradiation and then delayed surgery by up to 8 weeks. Short course RT and immediate surgery has almost gone out of vogue. It's not gone out of favor because the short course RT only ends up sterilizing the margins. Whereas if you want downsizing and downstaging, you would really have to give long course radiotherapy, or you'll have to wait for at least 8 weeks. So I think that's where the concept of TNT actually came in. Because when you actually wait for 8 weeks, you don't have to just keep doing nothing. You could actually end up giving them chemotherapy in the interim period. So I think, my clear consensus on this, and also my message to my opponent, would be don't focus on the past or you'll miss out on the future. And this was the Stockholm 3 study, which looked at delaying surgery by up to 8 weeks after short course radiotherapy. And that study did show us was that there was an improvement in the path-CR rates when you did that. But again, the recurrence-free survival and the overall survival is not much to choose from, but the path-CR rates were higher. So let's look at adjuvant chemotherapy and the data that we have currently. There is absolutely no level 1 evidence. There's not a single phase 3 RCT that has actually been positive for adjuvant chemotherapy. If you look at the DFS and the overall survival, as I've shown you here, agreed, yes, there have been a lot of criticisms. They've all been old studies, very poor accrual and suboptimal chemo regimens and poor compliance, all of that agreed. But having said all that, there's not one single phase 3 RCT or level 1 evidence for adjuvant chemotherapy. So, which again, I would really ask my opponent, show me the data for real adjuvant chemotherapy here. And this is probably the best of what we have. This is the phase 2 data called the ADOR trial, which looked at 5-FeLV versus FOLFOX. And yes, in patients with stage 2 and stage 3, there was a DFS benefit to the tune of around 8 to 9% absolute difference. So let's then look at the recommendations for adjuvant chemotherapy after pre-op short or long course chemoradiation. What is striking for me is that you'll have to talk to the patient and inform them about a lack of robust data and discuss the pros and cons of observation versus adjuvant chemotherapy. Key statement. And stage 0-1 observation, again, otherwise single agent 5-FP or gemcitabine. And even if it's stage 3, you still have to discuss the pros and cons of either doing single agent or doublet. So I think this is more like, anything goes. And there's absolutely nothing that anyone can draw concrete evidence from. So let's move to the present. And what are the new standard pre-op regimens after ASCO 2020? Well, we've seen that distant recurrences are a major challenge. Earlier delivery of systemic therapy, like, for example, moving from adjuvant to neoadjuvant chemotherapy might solve the risk. and might decrease this risk. And that's where these two strategies come in, where we do induction chemo followed by long course chemoradiation, or short course chemoradiation followed by. And I think probably that's the area that we would actually be debating on. Would you want to start with chemoradiation and then sandwich chemo in between, or would you want to start with chemo and then do chemoradiation? Because as far as I'm concerned, TNT is here to stay. And that's why it's become the new standard of care. So I think it's very important for us to live in the present. I think, Trump is no longer the present, so Joe Biden. So I think, it's very pertinent for us to believe in the present. So this was the Rapido study. Again, if you they looked at patients with high-risk rectal cancer, either had CRM positive, T4, N2, or lateral lymph nodes being positive, or EMVI. And look at the PathCR rates. There was a doubling of the PathCR, 28 versus 14%. And the primary endpoint of disease-related treatment failure was also met. And again, if you're going to harp on toxicity, I'm going to clearly put it, that's why I boxed it. No difference in the post-op complications and quality of life. And let's look at the other TNT trial, which is the PRODIGE 23 trial. And again, they looked at patients with stage 2 to 3 rectal cancer, where they started with chemotherapy, followed by chemoradiation, and then surgery. And again, as you can see here, clearly there was a doubling of pathological CR rates. And the primary endpoint of 3-year DFS was also met, an absolute improvement of around 7%. Here, interestingly, there was a reduced risk of post-operative complications with TNT. And again, there was no difference or no deterioration in the quality of life. So to my opponent, have you had enough? Well, there's more to come. Well, again, to add to those two studies, we have another phase 3 study called the STELLAR study, which we've had the results from as well. And that's also met its primary endpoint. And as you can clearly see here, has also shown an improvement in 3-year overall survival of around 10%, absolute difference. And then the POLISH study, the Buchko regimen as we call it, which actually led to all these TNT strategies coming in. So there's no such thing as too much data. And let's just have a brief comparison between the Rapido and the PRODIGE 23 trials. So if you look at it, patients on the Rapido study had much more aggressive disease, more T4 disease, more N2 disease, and also most of the patients, around 2/3 of the patients had MRF involved as well. So this was a slightly more higher risk subset of patients that were included in the Rapido study. I agree these are only cross-trial comparisons, but still just for us to understand as to how TNT should actually be done. So again, the PathCR rates, I think there's no doubting that. There was definitely an improvement in the PathCR rates when you did TNT. It was almost double. So I think it's time for me to put the final nail into the coffin, because I'm sure my opponent will argue saying that, but does the PathCR actually translate into a better survival? And this is the data that actually clearly tells you that, yes, having a PathCR does translate into a survival benefit. And not just in terms of local recurrence, but also in distant metastasis-free survival, DFS, and overall survival, as you can see here. Wait, I'm not done yet. So let's look at the last part of it again, which is again on response assessment. And can you actually do away with surgery as well? How could you do that? Could that be a subset of patients where you could just do a watch and wait strategy? And again, you look at using the MRI tumor regression grading scoring system, and then you have your imaging, endoscopic aspects, and clinical examination as well to qualify them as having attained a clinical and radiological CR. So this is the international watch and wait database. So this was actually set in motion by, the earlier studies by Angelita Haber-Gama, who's considered to be, the forerunner of all this watch and wait strategy. And well, this is not something which is a work in progress. As you can see here clearly, the 2-year local recurrence rates range from around 20 to 30%. Agreed, it does need a stringent protocol. I'll show you that as well in my next slide. And with salvage surgery, you're able to salvage almost around 80 to 90% of them. So I think that is, I'm sure my opponent, that would probably make my opponent's reaction, but don't worry, I'm not done. So these are the long-term outcomes after watch and wait protocol. So around 25% can fail at 5 years, and 8% can have distant metastasis. But this is key. The overall survival at 5 years, 85%, and the disease-specific survival going up to 94%, meaning most of them can be salvaged even if they have a local recurrence after the watch and wait protocol. So I think that's the future, and the future is already here. So, and as far as, can you do it in practice and how do you do it? This is how you would do it. You would have a digital rectal examination and a CEA once in 3 months for the first couple of years. And you would also need to do a flexible sigmoidoscopy once in 3 months, at least for the first year. Colonoscopy at 1 year and then at 5 years. And then imaging once in 3 months for the first year and then 6 monthly. So I think, yes, this is how it's done. And I'm sure my opponent will also say, is it safe? Can you do it? Has it been done in trials? Well, this is the OPRA study, phase 2 data again, which looked at organ preservation. So the primary objective was survival, and the secondary endpoint again being organ preservation. And interestingly, and both the arms had TNT, or it was either consolidation or induction chemotherapy. And patients who were on the consolidation chemotherapy arm, around 60% could actually end up having this organ preservation strategy. Whereas induction chemotherapy, it dropped to 40%. So I think that's probably a more interesting debate where we look at patients who actually receive consolidation chemotherapy could actually have, they have a higher percentage of achieving a clinical CR and a radiological CR, and thereby being eligible for organ preservation. So this is how it's going to look like, and this is how it's already looking like, and in the near future as well. So low risk, no doubt about that. I think it's straight surgery. We're not going to debate that. The intermediate risk and the high risk, TNT, absolutely yes, that's the way to go forward. And if you have a higher chance of reaching a clinical and a radiological CR, and a path CR rates are high. So yes, I think you would definitely opt for that strategy. And remember, I'm sure patient preference really matters here. I'm sure a lot of us would have seen it in practice as well. A lot of these patients with low rectal cancers, where they would really look at avoiding a stoma, or sphincter preservation is not possible. So I think that the wait and watch protocol is definitely a very valid strategy in those patients, for sure. So I think that's the new normal, and that's absolutely good as far as I'm concerned. And that's what the NCCN says as well. This is the bad and the ugly subset of tumor. They've already made TNT, or total neoadjuvant therapy, has become the standard of care. And it doesn't matter where you choose, the Rapido or the Prodige, but that's already become standard of care as far as the NCCN recommendations are concerned. So I guess this is the end for neoadjuvant chemoradiation alone. So I think this is how it is. Conventional chemoradiation has actually had a slip and fall, and it's time for it to rest in peace. And I'd like to offer my heartfelt condolences on writing this obituary for Lonca's chemoradiation alone. And with that, I'll pass on the baton to my opponent to continue with the commiserations on the demise of conventional chemoradiation. Thank you.